Everyone. Thank you for coming. My name is Heather Cimino. I work here at the library coordinating adult programs like the one we are putting on tonight. Before we get started, can everyone please make sure their cell phones are silenced? And also note that the emergency exit is in that back corner to your right. So we're very privileged tonight to have the Orthopedic Neurosurgery Specialists, otherwise known as ONS, here with us this evening. I know I have benefited, especially with my back pain, so I have firsthand knowledge of their expertise. So with that, I'm going to introduce Dr. David Bombach, who's going to take it from here and introduce the rest of our guests. Enjoy.
Super. Thanks, Heather. And thanks to the New Canaan Library for having us. And thank you all for attending. Appreciate you all being here. So like Heather said, my name is Dr. David Bombach. I'm an orthopedic spine surgeon with ONS. This is my 19th year of practice. For those of you unfamiliar with ONS, we are an advanced multi-specialty orthopedic practice and neurosurgical practice, really handling all aspects of orthopedic and neurosurgical care. We serve patients predominantly in the New York and Connecticut community, but we even take care of many patients that live in New Jersey and Rhode Island and Massachusetts because of some of the advanced specialties that we offer. We also have physical therapy at 4 of our 5 office locations. We have physical therapy in Harrison, Greenwich, Stamford, and Wilton. And then our 5th office up in Danbury is really a spine specialty office. We're lucky tonight. We have a great venue. We have Dr. Robert Merrill and Alicia Hirscht, one of our physical therapists. So I'm going to talk to you about the format tonight, and then I'm going to introduce Dr. Merrill first. So tonight we're going to be talking about back pain. What causes it? How do we prevent it? How do we treat it? And Dr. Merrill's going to start out specifically. He's going to cover some common conditions that cause back pain, and then Alicia will talk about some treatment options, conservative treatment options on how we treat back pain. Fortunately, when you have back pain, majority of back pain can be treated non-operatively. Even though we're surgeons, we use surgery as a last resort. We try to do everything in our power we can to avoid surgery, and then when you failed and checked all those boxes, then surgery becomes an option. So please join me in welcoming Dr. Robert Merrill. Dr. Merrill is a fellowship-trained orthopedic spine surgeon who specializes in all aspects of spinal care, both operative and non-operative, both adolescents and adults. He treats cervical, thoracic, lumbar conditions, degenerative conditions, deformity conditions like scoliosis, trauma, tumors, herniated discs. Let me give you a brief background on Dr. Merrill. Dr. Merrill did his training at medical school at the Icahn School of Medicine, which is Mount Sinai in New York City, and then went to do his residency at Albert Einstein in Philadelphia, and then came back to the renowned Hospital for Special Surgery in New York City, where he completed his spinal fellowship. So please join me in welcoming Dr. Merrill, who's going to talk about back pain.
All right, good evening, everybody. Thank you all for coming. We, like Dave said, like Dr. Bombach said, we all, really appreciate your attendance and being here. So my name is Dr. Merrill. I'm one of the new spine surgeons with ONS, and I'm seeing patients up in primarily Danbury, but also in Wilton. So like Dr. Bombach said, tonight we're going to be talking a little bit about back pain, kind of what some of the most common causes are of back pain and how we treat it. So we're going to start off with a little epidemiology, and that's kind of just a fancy medical term for how often this occurs, who gets it the most. It's sort of the geography of the disorder, if you will. And then we'll go on to talk about some of the most common causes, and then I'm going to delve into some more specific diagnoses, which are sacroiliac and facet joint pain, spinal stenosis, lumbar disc herniation, and something we call spondylolisthesis. So worldwide, back pain is one of the most common medical diagnoses and one of the most common problems that people go see the doctor for. So globally, it's estimated that 80% of the entire population at some point in their life will get an episode of back pain that prevents them from doing something that they want to do or going to work. And at any one point in time, it's estimated that about 7.3% of the entire planet is suffering from back pain. So that ends up being about 600 million people at one point in time. So that just gives you an idea of how common this is. It's also the leading cause worldwide of disability and reasons for missing work. So in order to understand what causes back pain, we have to get a little bit of an understanding of the anatomy of the spine. So this is looking at the spine from the side. This is looking at the spine from the back. And this is looking at the spine as if we were to kind of lay you down on your back and look at one of your bones from the top. And you can start to see that there are a lot of different structures in your spine. And this is a very complicated image, but the point of this is to show you how many different things there are that could be causing pain. So this is, again, kind of looking down at just a single bone from the top. And all of these dotted lines go out to an anatomic structure, and pretty much any one of those things can cause pain. And this is just a single bone in your back. So there are a lot of different things that can lead to back pain. And what this image and the previous image didn't even show are all of your muscles. And it's estimated that 80 to 90% of all back pain is muscular related. So despite the fact that there are a lot of different causes of back pain, it's important to try to relax because only less than 1% is something serious. And when we say serious, we're talking about a broken bone, cancer, some kind of major infection, or what we would consider to be an emergency that would require you to get rushed to the operating room. Those kinds of things are really, really rare. And it's estimated that 90% of all back pain episodes end up resolving within 1 year. So when you come to see us in the office, what are some of the things that we're going to do to try to help you get through your back pain episode? One of the most important things to remember, like I had mentioned, is that the majority of the time it's not something serious, and it's important to stay active. You might be in a lot of pain, but you want to try to stay active, stay out of bed, make sure you're walking around, still doing all of the activities that you normally do in your life within the limitations of comfort. Obviously, if something is uncomfortable or causes you pain, you want to avoid that, but you don't want to try to, tell yourself that you have to stay in bed for a week because your back hurts. In fact, we want the opposite. We encourage you to get up and be as active as possible. When it comes to medications, some of the main categories that we like to use to treat back pain are anti-inflammatory medications. These are also called NSAIDs, and some of the more common over-the-counter NSAIDs that you've probably heard of are things like ibuprofen, Aleve, Advil. Those are all under the drug class NSAID. One of the other things that we like to use are muscle relaxers. Like I had mentioned, about 80 to 90% of all back pain is thought to be muscular in nature. And so your muscles can start to build up tension and they can spasm. And so muscle relaxers can end up being quite beneficial for treating back pain. One of the other major classes that we use is steroid medications. And these are usually used after some kind of immediate injury that leads to sort of an acute onset, severe pain. And the point of steroid medications is to try to reduce the inflammatory response, which is pretty much what is responsible for what causes the pain. In terms of things that we can do that are non-medical, and Alicia will talk a lot more about this, our favorite thing that we pretty much prescribe to everyone is physical therapy. Physical therapy does wonders, and it can be very beneficial for back pain episodes. Besides physical therapy, there are a lot of other non-medical treatments that people try and find benefit from, such as chiropractors, heat, massage, acupuncture. All of these things can be beneficial. Some people don't find them helpful. Some people do. So it's one of those things where there's a whole lot of different things you can try that could help you out. Getting a little bit more specific, some of the diagnoses that we see very commonly are called sacroiliac and facet joint pain. And so at the very bottom of your spine, which is shown at the image on the left side of the screen, that's looking at you from the back, the very bottom of your spine is called your sacrum. It's kind of near where your tailbone area is, and your sacrum connects to your pelvis on each side, the right and the left. And it does that through these two joints we call the sacroiliac joints. If those joints get inflamed, they can become incredibly painful, And it feels like lower back pain because that's where they're located. So a large proportion of the back pain that we see ends up actually being what we call sacroiliac pain. Similarly, each of the bones in your back is connected to one another on each side by something we call a facet joint. And just like your knee or your hip can get arthritis and become painful, your facet joints can get arthritis too and also become very painful. When it comes to these two things, if you try physical therapy and some of the medications I mentioned and it doesn't help, what Dr. Bombach and myself and our other partner, Dr. Kramer, do in our office up in Danbury is we can do an injection under an X-ray guidance where we put some medication directly into these joints, and it helps provide some additional relief. And if it's in fact those joints that are causing your pain, you can get pretty substantial relief for an extended period of time from a very quick and simple injection. Another thing we see very commonly is something called spinal stenosis. And a lot of the images that I showed before showed your bony anatomy, your bones. And what your bones create is a little tube or a little tunnel where your nerves run through. That's called your spinal canal. And all stenosis means is that that tunnel where your nerves are running has narrowed. And if it gets too narrowed, if it gets too tight, there starts to be pressure that gets exerted onto your nerves, and you can start developing back pain. You can get pain that goes down your legs, and you can get this sensation when you walk too much where your legs start to feel really heavy. Some people describe it as like walking through concrete. That's what it feels like. And the way we treat this, like the other diagnoses that I mentioned, is we start with medications, physical therapy, and then the next step would be injections. Now, the injections for this are slightly different from what I described. The injections for this are done directly towards the nerves, and those are called epidural steroid injections, and those are done by pain management doctors who do those. And then if your symptoms are bad enough and they're not getting better with some of those treatments that I just mentioned, we can do a surgical operation where we try to remove some of the pressure on your nerves to relieve your symptoms. And nowadays, with the technology that has advanced in the surgical field, we're able to do this in very minimally invasive, safe, effective ways. So we use operating microscopes, and we use these retractors that are shaped like little tubes. So one of the ones that I use is 19 millimeters long, so just under 2 centimeters. And we're still able, through just that tiny little space, to take all this pressure off your nerves, and it helps prevent some damage and destruction to the surrounding soft tissue structures like your muscles. So these procedures can be done in a very minimally invasive and nonetheless effective way. Now, we've all heard of a disc herniation. So, people slip their disc, they herniate a disc, and what that means is when you have your intervertebral disc has a very soft center. The way that I think about it is like a jelly donut. So a jelly donut has sort of this hard outer bread coating, and in the center is the jelly. And a herniated disc, basically the jelly just squirts out, and it can go back into your spinal canal and cause what we just talked about, which is stenosis. It can cause pressure on the nerves. This can cause a lot of back pain. You can get pain that shoots down your legs all the way into your feet. And you can even develop things like weakness in your feet or your legs, numbness, tingling. And you'll start to recognize a pattern of how we treat this, that we start with medications, physical therapy, do some injections. And similarly, if you don't respond well to those treatments and your symptoms are interfering with your life and you're not getting better, we can do, again, very minimally invasive surgeries, similar to what I showed before, where we go in and we remove the disc that's putting pressure against your nerves. So the last thing that I'm going to talk about is something called spondylolisthesis. And if you look at this X-ray, in this X-ray, you're facing towards the right. We're looking at you from the side. So your belly is on the right, your back is on the left. And the dotted line you can see lines up very nicely with your backbones until it gets towards the bottom, where that line breaks. And what's happening there is that one of your bones has slipped forward relative to the bone below it, and that's called a spondylolisthesis. That can be painful. That in itself can just cause back pain. But because that bone has moved forward, it can also reduce the space for the nerves around it and cause stenosis, which can lead to some of those other symptoms like leg pain, heaviness in the legs. And the way that we would usually treat this is with something called a spinal fusion. And spinal fusion has kind of had this very mixed reputation because it can be done for a lot of different reasons, and a lot of people hear the word spinal fusion and they get very nervous. But when a spinal fusion is done for the right reasons, like this type of diagnosis, they're generally very effective, and people do very well when they're performed for the right reasons. And this is the goal of the operation, is to try to bring that bone back, and then we put screws and rods into the bones to hold it in place. And that not only stabilizes that slip, but it also creates more room for the nerves around it. So that's the last diagnosis that I'm going to talk about. To just summarize, back pain is something that's very common. It's one of the leading diagnoses. It's one of the most common reasons that people go to the doctor. It's the leading reason for disability and missed work. There are a lot of different things that can cause it, but most of the time it gets better. And in general, if you were to go see a doctor for back pain, the sort of treatment algorithm is start with some medications, physical therapy, then we can move on to some more invasive procedures like injections. And if that doesn't work, then we start discussing surgery as an option. So I think we'll probably end up saving questions for the end, which I'll be happy to answer any questions. And I thank you all again very much for your time. This is Dr. Bomback, myself, and our other partner, Dr. Kramer, and these are our two offices. We see patients in Danbury on the left and in Wilton now as well.
Excellent. Thanks, Dr. Merrill. So I'm sure a lot of you are sitting there saying, oh, I know I have spinal stenosis, or I've been told I have spondylolisthesis. So, and we'll get into some of that at the end. If you find yourselves leaning over shopping carts and that makes you feel better, and when you stand and walk and you feel pain down your buttock and down your legs, and your legs feel tired and heavy, and there's a good chance you might be developing symptoms of spinal stenosis. And it's nothing to be overly concerned about. It's a natural age-related phenomenon. This happens typically in the fifth or sixth decade of life, although even younger patients can get spinal stenosis. But as we all age, it's a normal process. So we'll get to questions at the end. I wanted Dr. Merrill to lecture for about 15, 20 minutes, and I want Alicia to do the same. So then that'll give us about another 20 minutes at the end for people to shoot out any questions that the panel can answer. So now that we've heard about a lot of causes of back pain, let's talk a little bit about treatment strategies for back pain that are non-operative. So we have with us today Alicia Hirscht. Alicia is our director of our physical therapy group in ONS in Stamford. She earned her Doctor of Physical Therapy from Northwestern University and has been practicing orthopedics and sports medicine physical therapy for 20 years now. She's board certified by the American Physical Therapy Association. She's also what we call a certified Schroth physical therapist, which is quite rare, and we're lucky to have her. There's only a handful of Schroth therapists, not even in Connecticut, in literally like the tri-state area. Schroth physical therapy is therapy really specifically designed for patients with scoliosis and what we call kyphosis, so hunchbacks or curvatures of the spine. And there's different types of scoliosis that adolescents might develop and that adults can certainly develop as well. Schroth therapy can be effective both for adolescents and for adults. So we're really lucky to have a Schroth certified therapist. It's very complex therapy to be trained on. It's not complex for the patients to do it. It requires some teaching techniques, but it's extensive training beyond normal physical therapy training. Alicia lectures regularly in the community on injury prevention, healthy training for adolescent athletes, and women's health. She's an athlete herself. She enjoys yoga, running, Spartan training in her free time. She has 3 children, so she's got her hands full, but she is joining us tonight to talk about how we treat back pain. So please welcome Alicia Hirscht.
Thank you all for coming. I see some familiar faces. As Dr. Bomback said, I've been practicing for 20 years, and if I caught your how long you've been practicing that makes me the senior here tonight. But I will say, as she brings up my presentation, 20 years ago when I did my training, everybody was fused. Everybody was in the hospital for a week. Everybody got a back brace for 3 months. When people ask me what has changed the most in the PT practice the past 20 years, it's definitely spine surgery, for sure. You know, now we can do in and out surgery, same day discectomies. It's amazing what we see. Fusions are more rare, I think. I see that clinically anyway. And ultimately, I think while I champion conservative management, being a doctor of physical therapy and practicing for 20 years, if you do need surgery, it's not all is lost anymore when it comes to spine surgery. Most patients do get back to their previous quality of life and all of their previous level of functions and activities, and it's a great way to improve your quality of life and reduce chronic pain. Like I said, I think I'm always on board for exercise and conservative management and education and managing your life so that you can manage your pain. But if you simply do need surgery, the outcomes are phenomenal these days, better than ever. Okay, so just to review the objectives that I'm going to talk about tonight. When we talk about conservative management, I must say this 10 times a day, and I say this to almost every one of my patients, whether you're a back pain patient or a shoulder pain patient. Conservative management, I'm examining you, and I'm basically coming up with where you are deviated from what we know to be healthy and normal. And what I mean by deviated, I'm trying to figure out what is impaired. I'm going to have you go through your range of motion of your back, bend forward, try to touch your toes, bend backwards, try to look up at the ceiling, twist, move. We're going to look at your strength, your flexibility, your joint mobility, and anywhere you are deviated from normal, which we call impairments, we're then going to address with our therapeutic techniques, okay? So today we're going to discuss the impairments that I commonly see with my back pain patients, and then the exercises that I usually give out. I do have a handout of exercises for all of you to take home tonight. It's very low level and basic because it's made for a general population with some basic back pain. Some of you might need more advanced intervention, so that's where you come see the doctors, that's where you come to see therapy, but you will be leaving with a handout of basic exercises. And then I like to talk about lifestyle changes and fads and things like how you should sleep and sit and whatnot to reduce your incidence of pain. So Dr. Merrill already went over all the anatomy, but one of the first things I see is what we clinically called hypomobility. So hypomobility to me is a stiff joint. Whether it's your shoulder or your back, we have a lot of soft tissue, a lot of ligaments. We have this fibrous disc, which is actually exactly the jelly donut that I use every day as a comparison to my patients when I'm explaining what a disc is. Those soft tissues, those ligaments and discal connections in our spine, they stiffen with age, normal age-related wear and tear, and they do get a little stiffer as we get, depending on how we move, whether or not we're moving, whether we've been a laborer our whole life and moving too much or moving in maladaptive ways or just sitting too long, I see a lot of stiffness, okay? And then we talk about inflexibility or good old-fashioned tightness. So a lot of patients come in and they say they can't touch their toes and they're so stiff and they're so tight, but then they lay down on their back and I look at the length of their hamstrings, which is the muscle on the back of your leg. Everybody says they're tight in their hamstrings, and I have people who can actually get their leg all the way up to the ceiling. And they're not necessarily inflexible, they're just so stiff in those back joints that we talked about. But when we do talk about inflexibility, we're talking about length of muscles, the muscles and the tendons that connect there's several layers, there's about 2 or 3, 4 layers in the back and in the stomach, the front of the spine, the back of the spine. There are a lot of muscles that connect from our hip to our buttocks to our back, and it's all connected with this saran wrap-like tissue called fascia, and all of that is soft tissue. It's all connective tissue. It can get stiff, it can get tight. So the two things I see most commonly with patients who are all our age, right, so maybe middle-aged and older, are stiffness and tightness. So we're talking about the joints being stiff, the muscles being tight. So this is just another diagram of all the different muscles that connect the spine to itself, but then to our pelvis and our hip bones and all the muscles that I do see tight. Hamstrings are the back of the thigh, and those can often get tight in patients who sit a lot. But the other muscle that's less commonly spoken of, but more commonly seen clinically that can be tight, the picture on the right side there, are the hip flexors and the quadriceps. So you don't think about this on the front of your body, the front of your thigh, that could impact your back. But if we sit all day and our hip flexors get tight, and then we go to stand up and we can't stand up, it's because those hip flexors have shortened and we can't get straightness through that hip and into our back. Okay? And then, of course, we see weakness. So our muscle strength is directly related to how much we move and how much we exercise. And as a culture, even younger generations who are typically healthy, we're moving less so than, let's say, 100 years ago, right? And we're sitting a lot more, and ultimately our muscles are there to produce force, but then also to absorb force. So if you don't spend time strengthening your back and your core and your hips, and then you go to move your granddaughter out of college or help your kids move out of their house or something, or you're babysitting your 4-year-old grandson and he wants to jump all over you, and you're picking up and lifting and throwing him up in the air and whatnot, this is a good structure or a picture showing you how much different forces are engaging on your back all day with different movements. And the only way to prepare to absorb those forces and not get hurt is through exercise. Strengthening. So then, this is just another slide talking about how important strengthening is, because if we are weak in our front muscles from sitting perhaps all day, or we're just not strengthening, or maybe we're walking but we're not necessarily doing any core work or back strengthening, these forces play on the front, on the back of our spine, sideways, twisting. We have a lot of planes of movement in our spine and in our hips. And throughout the day, again, our underlying level of strength, which is dependent on how much we're moving and how much we're exercising, is going to determine how well our spine can absorb those forces. And when our spine is a little stiff and our hips are already a little tight, and then you combine that a little bit of weakness, and then you start to move, maybe you decide to go work out, maybe you decide to start a walking program, maybe you just take a long trip and you sat for 8 hours, and all of a sudden you're starting to develop pain. This is usually why. So patients often come to me and say, I saw the doctor and he says I have a herniated disc, which is great that I know that diagnosis, but when I examine you, I'm looking at all these other things. What are the underlying reasons? Nobody just pops a disc all of a sudden. Most things are festering at this age. Most things have been going on for a long time. Most classically, people come in, I hurt my back 10 years ago, it went away within a week. I hurt my back 2 years ago, I had to see the doctor, got a Medrol dose pack, it went away after 2 weeks. Now I hurt my back again, and it's not going away. So something's been lingering and festering for a decade in that case, right? And so working on someone's back and identifying the underlying issues, sometimes patients say, well, I never had a hip issue. Right, but you're tight in your hips, and those muscles are affecting your back. So we look at everything, all of those underlying impairments. And again, to review, what we see most often clinically is stiffness, tightness, and weakness. So then what do we do about it, right? So some of you who have been to my clinic, sometimes you see us, we have them all lined up. If we happen to have a bunch of back patients all at once, face down on tables, and all the therapists are leaning on their backs, it looks like we're giving CPR to our patients, but we're not. But we're working their backs, we're mobilizing their backs. And then if you ask the patient what we did, they're like, oh, I don't know, it felt good and it was like a massage. But really what we're doing is we're poking on those vertebrae that you saw in the anatomy pictures, and we're trying to loosen the ligaments. There is some evidence to show when you mobilize any joint, you'll help the joint capsule to produce some healthier joint fluid, and that can hopefully reduce pain. But you know, what I see clinically is a lot of people are sitting so much that they've actually lost this. Like you can see this tennis player, I think that's Nadal laying on his stomach. All of my kids play tennis, so I like to include tennis in every lecture. He has a normal curve to his lower back there. We call that a normal lordosis curve, and I'm sure the doctors can attest to this. A lot of the patients that they see who are coming in with back pain, whether it's a disc, arthritis, stenosis, they usually have lost that curvature in their back. And we mostly attribute this to how much sitting we're doing as a culture. But essentially, we're working on people's backs. We're mobilizing their spines to loosen those ligaments, to improve the mobility, so that you can restore your lordosis and gain a little bit of motion and reduce your pain, okay? So lots of hands-on stuff, face down. I get patients face down, they'll say, I haven't been on my stomach in 20 years. Well, no wonder why you have back pain. If you think about it, when we were born, the goal of life was we came out flexed and we had to straighten. And then at some point in life, we start to get flexed again. So one of the best things we can do is just straighten up. And one of the easiest ways to do that is lie on your stomach. Stretches out your hip flexors, stretches out your stomach muscles, mobilizes your back. So if you can get on your belly, even just for a couple minutes a day, that's going to do wonders for your back pain. So what happens when we develop hypomobility and flexibility and weakness? One thing we do is mobilize your spine. This is just another example of the anatomy and how forces play on our spine. So again, I probably said about 3 or 4 times, we spend so much more time sitting as a culture between driving and we sit for meals and we sit for lectures. We're just generally, especially in this year, so many people work in business, finance, administration. We've spent a lot of time sitting. And even if you are exercising daily, and even if you're still working and you have a standing desk, and even if you're retired and you're walking every day, we still spend more time sitting than we do standing in erect posture. And so we start to lose that normal lordosis, and then the pictures along the bottom show that with that repetitive strain from sitting, you're actually putting more repetitive strain on the front of your vertebrae or the front of the discs, which makes that jelly bust out the back. So what it does is it takes the ligaments along the back of your spine that hold the jelly of that jelly donut or the herniated disc in, those start to compromise, they wear and tear over time, and that's why the jelly tends to push out the back, where it could potentially pinch on a nerve root and cause you that pain, numbness, tingling, weakness down your legs. How did I get like this? Well, I don't know. How did we get? We're all sitting right now. We should all stand up, right? We got like this because it's cultural. Computers, for me, and these guys, job security, right? Everybody's sitting at a computer all day. And it used to be laborers, but I see way more people who are sitting most of their day with back pain and back injury than I do laborers. So how do we fix this? You know, other than the age-related changes, for those of you who are still working, we do a lot of education about how to set up your computer. It's not just about the setup, but how to get up more frequently. Even if you're retired, if you spend an hour or 2 a day at the computer, you really should get up every 20 minutes. That's my recommendation, every 20 minutes. We're built to move, we're built to stand. That's how we should be. Even if you get up every 20 minutes for just 1 minute and bend your back, do a little twist, you know, get some blood pumping to your back, and then sit back down, your risk of developing back pain from a 2-hour session at a computer is less if you're getting up every 20 minutes. Poor posture, poor body mechanics. Hopefully not many of you are lifting heavy objects on a regular basis at this point in your life, but if you are, obviously you have to bend with your knees, not with your back. We have to make sure you have the flexibility in your knees to be able to bend with your knees. So that's what we do in physical therapy. We address the whole picture. Okay, so a typical patient, 42 years old like I described, back pain incident 10 years ago, back pain incident 2 years ago, and now they're here, they can't get rid of the pain. That's where we come in. And we already talked about how I examine the whole body. We find where they're impaired to be compared to normal, where are their impairments, and we put together a plan. Wants to hit a killer inside-out forehand to win the match. Okay, does any of you play tennis still? Good, lovely, I love it. So, you know, at some point we all have back pain. We know this, right? The incidence is almost 100% in the world. And at any point, some of us might be in pain right now. But essentially, the typical patient is stiff. They've lost that lordotic curve. They have weakness. They have some tightness. And then we come in and we take care of it, okay? So when we address the stiffness, we're talking about those ligaments. We're talking about the spine, the joint connections. We're mobilizing you. So we're literally pressing on your back and trying to loosen up the joints. And sometimes we'll even use pieces of equipment to help with you. I have a belt. I'll strap someone to the table and have them press up with the belt holding their back because it actually helps to really mobilize the spine. But we're putting our hands on you. We do manual work. It's not necessarily massage. We're stretching you out and we're mobilizing the back, trying to loosen up all those joints. These are ways that I'll educate my patients to self-mobilize. As you can see, there's a girl doing a common back pain exercise. We call this in the clinic a press-up on the tennis court. Okay, that's a good, healthy dose of lumbar extension. Most of us don't still have this after 40 years old. So, and then the next picture, they're bending over backwards on a foam roller and or on a ball. I mean, this kind of extension is pretty aggressive, and I don't recommend people doing the ball or the roller, but the press up is very easy to start with. And like I said, you get on your stomach and you can tolerate that for 5 minutes, you're doing wonders for your back. So when we address the stiffness, the tightness in our muscles, we do want to stretch, right? So these are just common stretches, and you don't have to pay attention to these exercises so much because most of these are also on the handout that I have for you. We'll probably just set it up at the back. You can grab it on your way out. But the first picture, he's doing a common hip flexor stretch, and the way he's leaning, that incorporates a little bit of IT band stretch on the side of our hips. The second stretch on his back, he's just lifting his leg up and holding it. That's a hamstring stretch, very effective. The next one is a picture of a PT doing a hamstring stretch. So if you ever come through the clinic, you see a lot of us doing this too. So when we're hands-on with you, we're mobilizing your spine. We might even work our way up into your thoracic spine, which is where your rib cage connects as well. We'll work those sacral joints. We'll stretch out your hip flexors. We'll stretch out your IT bands. That's what we do. That's the art of what we do hands-on. So he's kneeling. On the back leg, that's a hip flexor stretch. So the front leg is just there to hold you up, and the back leg planted on the ground is stretching the hip flexor, which is the front of your thigh, and it flexes your hip, right? So it's this. But the hip flexors actually originate in your spine and your pelvis. So when they get tight, they can contribute to back pain, and they also help to stabilize your pelvis. So that's why we stretch them out. And these are very general, and again, when we examine a patient, again, we're looking at the whole body and addressing all of the impairments that we see, but there are specific things that we do for a patient with a herniated disc that we might not do for a patient with stenosis. So these are very general and safe to do, but again, if you have a specific diagnosis and or experiencing pain that you want specific intervention for, you'd have to come to the clinic. So these are some basic strengthening exercises that I use these all day long. So the first one's a bridge, lying on your back and lifting your hips up off the table, or I say the table because in the clinic that's where we have treatment tables. You could do it on the floor, you could do it on the bed. You'd be surprised how many people with back pain can't even lift their hips up, but yet they're walking throughout the day and they're getting up from a toilet every day, getting in and out of a chair, getting in and out of a car, and then they wonder why they have pain. They're so weak they can't even lift their hips up. The next exercise, we call those Supermans. Someone's lying on his belly, and he's literally just extending his head and shoulders, trying to strengthen all of these back muscles here from the waist up. The next one, we call this bird dog. I have no idea why. I think because you're flying with your arms and you're kicking out your leg at the same time, but that bottom left picture has a lot of evidence to support that strengthens the stabilizing muscles in your back. Pretty simple to do as long as you can get on your hands and knees. And it's not the kind of exercise that you're going to feel the burn or lose your breath or bulk up, but it's a great way if you can do on your hands and knees, alternating one leg and the opposite arm extended out like that, and you don't fall over and it doesn't hurt, then you're doing a great job. And the next one is just a variation of that on your stomach. So these are a little bit more advanced exercises, which I will kind of go through, but like I said, there are exercises on the program that I brought, and they're a little bit more basic than some of these. But these are all great exercises that I have my patients well into their 90s doing in the clinic. Like something like a basic squat, the girl in the top right corner. We all get up and down from our kitchen chairs, and we all get on and off a toilet. So if you can't squat, how are you getting on and off a toilet, right? And that's when patients might say, well, I'm holding on to the toilet paper holder, and I'm holding on to the sink, and I'm holding on to the bar that I put in, which is all great. But if you can strengthen your legs and your back to be able to support your weight, you can do that more frequently with better balance and less pain. So lifestyle changes. On the left, that's the setup of that's the picture of a proper setup if you're working with a computer. So we often say 90, 90, 90. So she has about a 90-degree angle at her elbows, 90-degree angle at her back, and a 90-degree angle at her knees. Most people are working with laptops these days, but I don't like laptops because you have to look so far down on the screen. If you are working with a laptop at all, I do recommend getting it up on a riser or some reams of paper, getting an external keyboard. So take your laptop and create it just a screen, and then get an external keyboard or a wireless keyboard to be able to keep your arms down low. So you're not like this, but you can keep your vision to the screen at a more appropriate angle for your neck. The picture on the right is what's called a McKenzie lumbar roll or a super roll. I get nothing from McKenzie, but I think this is the best lumbar support you can get. We sell them in our clinic. You can get them on Amazon. So if you are spending any time in a car or you're still working, you're at the office or a computer, a McKenzie super roll is the best lumbar support you can get for your chair. Lifestyle changes, I always say there's no smoking gun. However, the big picture should involve not just PT, but exercise regularly, eat well, sleep well, manage your stress, right? Vitamins, nutrients. That's a whole nother lecture, but people do ask about that stuff in physical therapy. What's good food, what's bad food, sleep, stress. You all probably know this from just being you're at this lecture, so you're interested in education, right? At the end of the day, we have to sleep well, we have to manage our stress, we have to eat good, can't live on candy bars and expect to not have pain at some point, right? Workplace habits, we talked about computer setup, so that's sleep positions. Oftentimes people say, how should I sleep? I just tell patients, I'm not here to drastically change everyone's sleep habits, but I just want you to remember how much time you're spending what we call flexed. So everyone who's sitting is in what we call a flexed position, and as soon as you're upright, you're now in an extended position. Our bodies like balance. So if we're spending a large amount of time in a flexed position, then we don't always need to be flexed at night either. You're not necessarily going to have pain in the fetal position, but you might not be doing good for your back to always be in the fetal position. So I do recommend bolsters and king-size pillows and husband pillows, and try to sleep like this patient here who's like half on her belly, half on her stomach, one leg straight, one leg bent. The fetal position can actually wreak a little bit of havoc on your back, especially if you're getting out of bed first thing in the morning and your back hurts. It could be attributed to how you sleep. Coping with stress, meditation. Like Dr. Bob Mack said, I work full time and I have 3 kids. My meditation is 5 minutes in the car alone before I go into the house. Good luck. If you can meditate and you can de-stress, then you're winning at life. But just know the important take-home message is stress is related to pain. So when we talk about any type of back, especially in the back, so when we have any type of lecture about back pain prevention, we have to talk about coping skills and stress management. So be mindful of that. And then in general, when you exercise, if any of you are exercising regularly, you don't want to overdo it, you don't want to underdo it, but if you're using your sport as exercise, for example, you play tennis and you consider that to be your exercise, or you're playing golf and you consider that to be your exercise, I tell everyone we have to condition in order to do that exercise. Even if you're swimming or you're just walking, a good baseline program of strength and stretching for your back and your hips and your core will do wonders for you in order to be able to keep walking, swimming, playing tennis, etc., pickleball, whatever. So there's some evidence to link injuries in sports to people who are stretching beforehand, not necessarily in the back, but I put this in here because a lot of the lectures I've given in this community are a lot of tennis players and golfers. So I tell them don't stretch before. I like active warm-ups, and I like stretching after. But we don't want to stretch necessarily before your sporting event. I know, that's like a big one. Everyone in the clinic, God bless you, everyone in the clinic is always like, why? Why wouldn't I stretch? But if you think about it, you're weakening the muscles that are trying to contract and produce force for your sport, for example, right? So the last thing you want to do is overstretch before you're about to go contract your muscles and produce force. So I like dynamic warm-ups, active warm-ups. For golfers, I give all of my golfers with back pain a proper warm-up so that they're loosening and creating heat. We call it a warm-up because your muscles are pumping and you're producing heat, right? So that's what I like to do, dynamic warm-ups, whether you're jogging, playing pickleball, anything else, any sports I've missed that are common to the area, bowling, what have you. I like a good dynamic warm-up. Do your competition, do your sport, and then you can stretch after, or just stretch as part of your baseline routine to gain flexibility, but don't necessarily stretch before you go play your sport. An active warm-up means you're producing heat and you're moving your muscles, whereas a stretch is just you're holding it and stretching, right? So to take golf, for example, I teach patients to take a golf club and they do rotations, they'll do some flexion, some bending, golf club go up and overhead with the golf club, right? As opposed to a golfer who just does this or does this and then goes and plays golf. That would be a stretch, whereas what I teach is a dynamic warm-up. Oh, and then I just say be mindful of fads. I like the desk setup. I don't think many of you are sitting with 5 monitors in front of you anymore. Hopefully you're all retired from that kind of work, but if you are, walking on a treadmill while working with 5 monitors is pretty intense, and I'm not sure it's the most effective use of your skill set. Maybe stand while you're looking at the monitors and save your walking for a different time. I've treated plenty of patients, believe it or not, who have fallen on their work treadmill desk with their injuries. So be careful of fads, and you can't be laying on a lazy boy while you do computers, maybe gamers, but not that. And then I do like cycling, and so the reason I put some cycling on here is I'm just very mindful for patients with disc issues. Too much repetitive flexion or activity in a flexed position, which is cycling, rowing, those are seated flexed exercises. I don't always love them for my patients, and they might think, my back hurts, so I'm going to cycle instead of go for a walk. But evidence has shown the walking is better for you because you're more erect and you're standing. So I just do a lot of education with my patients about what appropriate exercises are best for patients when you have back pain. So be careful of that. And that's it.
That was great, Alicia. All right, so you basically, just to summarize, you basically heard a brief sampling of causes of back pain, and we tried to keep it fairly general. We can get a little more specific now if need be. And then a really nice overview of not just treatment, but really prevention strategies, making some ergonomic adjustments at home, in the workplace. That super roll, that lumbar McKenzie roll that Alicia talked about, those are not expensive. You can get them on Amazon for like $10. But they make a world of difference. Even if people put them in their, not just their workplace, but even in their cars. Just driving with a lumbar roll can be helpful. Some of the newer cars even have built-in lumbar rolls. When you control the electronic adjustment, it'll give you a built-in lumbar roll, because we all tend to sit in a very flex position. This talk is not about neck pain, but we're all texting, and there's a syndrome now called text neck syndrome that a lot of physical therapists are treating. And we see it a lot, way more in adolescents than we do in adults now, but everyone's on their phones and texting and social media, and people just come in with horrible posture. So we're in a society now, this digital age, where we are not in a great ergonomic setting. So some of those strategies are really helpful, as well as the prevention strategies that Alicia talked about. Really important. She went through that slide quickly, but it's really important. I always tell my patients, carrying an object out in front of you versus close to your body, the amount of force on your back is drastically different. And carrying an object when you're bending down versus in a more upright position. So don't move that couch. You're going to have to kind of bend down. You're going to get 2 or 3 people, and you're going to move a chair in a more ergonomic position. We see a lot of injuries from incorrect positioning. I think that concludes our program for tonight. I want to thank everybody for coming. I want to thank Heather and New Canaan Library for having us here.
Thank you, ONS.
For coming.